Hey guys, it's Gianna, Midwifay. Today I wanted to talk about a topic that is becoming increasingly popular in the OB world, and that is elective induction of labor at 39 weeks. Because of how popular it's becoming, some people are calling this a risk-reducing induction. So I want to talk about, what does that mean? Does this actually reduce your risk of anything? What is everyone talking about? What's all the buzz about? Go over the study that caused this to come up, the ARRIVE trial, and talk about the pros and cons of it. Let's get into it. So before talking about the elective induction of labor study, I want to just talk briefly about induction of labor and define it. A labor induction is whenever we, medical providers, use different medications, tools to induce labor before your body has gone into labor on its own. Historically, and even still, we do labor inductions for a variety of medical indications, such as high blood pressure in pregnancy, preeclampsia, fetal growth restriction issues with the baby, gestational diabetes on medication, other maternal comorbidities that require induction of labor. I'll have a separate induction of labor video where we go over different ways that we do this, and there's different indications for inducing labor. And historically, we've only induced labor for medical reasons instead of elective ones, because there's been the belief and common practice understanding that whenever we start a labor induction, there is a higher risk of cesarean birth. Whenever we start a labor induction, we use something called a Bishop score in order to evaluate what method of labor induction would best help you go into labor. The Bishop score is something that we come up with after we check your cervix. It takes into account 5 things: your cervix dilation, your cervix position, your cervix effacement, how thin it is, your cervix consistency, how soft it is, and then the fetal station, so how low in the pelvis the baby is. This Bishop score was created in the 1960s by an OBGYN, and again, we've used it for years in OB practice to kind of determine, is this woman's body ready for a labor induction? We call that favorable. That would be a score of 5 or greater. Or is it not quite ready? That's a score between 0 and 5. So usually when we're determining a method of induction for someone, we take into account this Bishop score to see how much cervical ripening, how much preparation do we need to give her body and give her cervix before we start the active labor portions. Again, I will have a whole video on induction of labor and kind of the different methods we use, but I just wanted to have this discussion of Bishop score in because it's important for this risk-reducing induction topic. So historically, we've really tried to reserve labor inductions for medical indications, especially for first-time moms, because what we have seen in practice and what a lot of studies showed prior to this ARRIVE trial study is that whenever we induce labor on a non-favorable Bishop score, especially in a first-time mom, the chance of that person having a C-section increases dramatically. So we didn't want to just induce people without a true medical indication. Again, especially a first-time mom whose cervix isn't necessarily favorable or ready for labor. However, in 2018, everyone's minds were blown when this study, the ARRIVE trial, was published in the New England Journal of Medicine. The ARRIVE trial stands for a randomized trial of induction of labor versus expectant management of pregnancy. This study was done over about 41 U.S. hospital facilities. It was composed of about 6,000 participants total, 3,000 randomized into each arm of the study, and it was composed of only full-term women with low-risk pregnancy having their first baby. The baby was in the head down position, and again, they were low risk, meaning they had no other medical or pregnancy comorbidities. The goal of the study was to kind of find an optimal timing of delivery. So it was to look at if inducing labor at 39 weeks decreases the risk of serious neonatal complications like neonatal injury, neonatal hypoxia, and even neonatal death. Again, the study was done in about 41 hospital facilities. All, I must point out, were pretty academic facilities with maternal fetal medicine service, and they all had kind of strict protocols for labor induction, including the early part of labor induction, that cervical ripening phase, to get someone's Bishop score from that 0 to 5 place. So there wasn't a specific protocol that every hospital followed, but they highly encouraged the practitioners to allow for cervical ripening, if that takes however long that takes, before beginning kind of the active induction of labor phase. This study is considered a high-level study because it is randomized. So whenever we have randomized studies, that means that randomly people are assigned to one group or another. That's generally considered kind of the highest level of evidence in research. So again, there are about 6,000 women that participated in this study, about 3,000 in each arm. They were all very, very well counseled on labor induction and the process therein. They were just described to what the procedure was, what risks and benefits possibly are, what the study was looking for. And so these women were randomized into two groups. One that was induced between 39 and 39 weeks and 4 days, and the other that was called the expected management of pregnancy group. And that group waited till at least 40 weeks and 5 days of pregnancy before doing an induction, unless any other medical issues arose before then. So one important distinction I want to make here when discussing the ARRIVE trial is that this was really one of the first studies that looked at induction of labor versus expectant management of pregnancy. When I said earlier, that we have lots of data as well as just anecdotal evidence and experience showing that when we induce labor versus spontaneous labor, we have higher risks of interventions and complications. This did not look at induction of labor versus spontaneous labor. This looks at induction of labor versus expectant management of pregnancy. So that's watching and waiting and see what the rest of pregnancy has in store for this woman and this fetus. This is an important distinction to make because I think a lot of us assume, I will say myself as a midwife, I assume a lot of times that spontaneous labor is the alternative to induction. However, that's not true for everyone. So if you don't get induced, we don't know the chances that you will develop preeclampsia or other hypertensive disorders of pregnancy, or some kind of low fluid with baby, or growth issues for baby. So again, I think that's an important distinction to make, that this was the first study really that looked on a broad scale at induction of labor versus watching and waiting and seeing what happens the rest of pregnancy. So let's take a look at the findings of this study. Again, remembering that this study sought to look to see if there was a decreased risk in serious neonatal complications, injuries, death. The primary finding of the study was that there was not. There was not any real significant difference in the amount of neonatal complications or neonatal deaths that occurred in the induction of labor group versus the expectant management group. There were two secondary findings that the study found that we have kind of learned a lot from in the OB world. The first one is the decrease in C-section rate in the induction group. In the group of women that were induced at 39 weeks, the C-section rate was about 19%, versus the group of women that were expectantly managed for the remainder of the pregnancy, that C-section rate was 22%. So that 3% difference in C-section rate was considered statistically significant in this study. As the study designers put it, in other words, one cesarean delivery can be prevented for every 28 low-risk first-time moms that were induced in labor. The second major finding that came out of this study was a decreased rate of blood pressure disorders of pregnancy in the induction group versus the expectant management group. Those numbers were 9% for the induction of labor group and 14%. So also again, that 5% difference being statistically significant. So the reason why a lot of OB providers and practitioners are starting to call this elective induction a risk-reducing induction at 39 weeks is because of those two findings that were statistically significant: the decrease in cesarean rate and the decrease in rate of preeclampsia or hypertensive disorders of pregnancy. So let's talk about the implications of these findings and what they've meant for OB practice nowadays. As I said earlier when describing the study protocol, and I have linked a link to the full study if you want to read all pages of it to take a look at it. I said it was a really well-designed study. It was a large study. It was done in multiple facilities with a variety of OB providers. Those all make it a very high-quality study. However, all studies, including this one, have flaws. So here are some of the ones that I wanted to bring up today. Firstly, the internal validity of the study itself is challenged by selection bias. So internal validity is a research term that's used to describe how generalizable these findings are to the general public, and there's a variety of things that affect that, one being selection bias. Selection bias refers to the makeup of the population that underwent the study. So for this study in particular, let's take a look at the population of women that were included in this study. The study points out that 50,581 women could have been in this study. They would have been candidates for this study. However, over 16,000 women refused to participate in the first place or declined to participate. So that leads you to think, why are women declining to participate? Is this something that overall the general population of pregnant women wants? Some other points about selection bias of the study is the demographic makeup of the women in the study. For instance, women under the age of 35 were overrepresented in this study, as well as Black American women were overrepresented in this study. And again, the reason this is important, this selection bias is important, is because to say that these 6,000 women that undergo these studies, is this reflective of the average American first-time woman who was pregnant? And if it is reflective, then it is generalizable to the general public to say this. However, given that a large portion of women declined to participate in the first place, shows that a large variety of women, don't necessarily want to be induced. So that's something to study further. And then secondly, looking at the demographic makeup, the average first-time mom in America is 30. So the fact that the average age of the women in this study was around 24 doesn't necessarily reflect the current population of first-time moms in America. Another big flaw in the study that I'm not sure there's really a way that they could get around is just the topic of when you know you're being watched, you do better. So this goes on both sides. The research participants were thoroughly educated by research nurses on the induction process, what it looks like, how long it can take, potentially 24, 36, 48 hours even. They were very thoroughly educated on what this looks like. So the women going into the induction had proper expectations, kind of knew what to expect, and were mentally prepared for that. And on the flip side, with practitioners, when they know they're being watched, they do better. So the C-section rate in the expectant management group, which was the higher of the two, was 22%, okay? These providers knew that their patients were participating in the study that was looking at their C-section rate. The average C-section rate in American hospitals is anywhere between 30 to 34% for a first-time low-risk mom. So nowhere near that 22 and definitely not that 19% rate. So I say that to say the study designers encouraged OB providers to really follow strict induction protocols, cervical ripening protocols to allow significant time, and not to call a failed induction and do a C-section ahead of time, ahead of the appropriate protocol. So again, the fact that people were being watched and they knew their C-section results were being studied very likely skewed their behavior, what they would usually do without there being a study in place. So again, these women were highly educated, prepared mentally for a long labor induction process, which I think a lot of women these days aren't necessarily as thoroughly educated. It's hard to explain fully what they're getting into. So that was one side of it. And then the OB practitioners were aware they were being watched, strictly adhered to induction protocols, including adequate cervical ripening in that very early phase of labor induction. And all of these things very likely led to the decrease in cesarean rate. In terms of the decreased risk of preeclampsia and hypertensive disorders of pregnancy, that was a really groundbreaking risk that we saw was reduced. Again, as I pointed out in the beginning of this video, this was one of the first studies that looked at induction of labor versus expectant management of the rest of pregnancy. So there's no way for me as a midwife, for your OB, to really predict in a normal, healthy, first-time mom who is going to get preeclampsia and who isn't. I think, we know that the longer you're pregnant, the higher the likelihood of preeclampsia. So it's pretty logical that that would happen. However, to see the actual numbers is interesting and does bring up a point for further study. So the study did not specifically tell us how many women, at 40 weeks and 1 day developed preeclampsia and needed to be induced, and that induction resulted in more interventions and resulted in a C-section, for the indication of preeclampsia of pregnancy, right? That is what we can know and learn about this. So that's another area of further questioning of this study, is that we know the women that were induced at 39 weeks from the beginning, but we don't know the number of women in the expectant management group that developed a complication such as preeclampsia that necessitated an induction. That induction led to interventions, led to, fetal compromise in labor, led to a C-section, right? So those reasons could very likely be why the C-section rate was increased in that expectant management of pregnancy group. So now that we've talked all about the study and its flaws and its findings, let's talk about the implications. Did these study designers, did they say now everybody should be induced at 39 weeks if they're a first-time mom and low risk? Hands down, this means that we're reducing risk, everyone should do it? Not necessarily. They said that it is reasonable for practitioners to have this discussion with their patients and discuss this findings and to offer this if the woman wants it. The study designers mentioned 3 main things that need to be looked at before we automatically assign everyone to induction at 39 weeks. Firstly, the cost to the system. We know from the study that the women in the induction group spent a great amount more time on the labor and delivery unit, which is more costly to the healthcare system. More hours of nursing, more supplies, more one-on-one time. What cost does that have to our healthcare system? I can say, having worked at many busy facilities, including the one I work at now, we already induce, for medical reasons, generally about 20 to 25% of the population. So if we're adding this is going to significantly increase the demand for nursing staff, OB staff, midwife staff, anesthesia, resources that we may or may not be able to handle when we already do 600 to 700 deliveries in a month. The second thing that the study designers really focused on is that, again, it's reasonable for OB providers to begin talking about this and offer this to their patients. However, they really need to look carefully at their induction of labor protocols and policies to ensure that they are providing adequate time for cervical ripening as well as the labor induction process. Again, this study was done across 41 different facilities, but they were all academic facilities with maternal fetal medicine service. So that implies that they're following evidence-based protocols. And again, these research nurses and the people studying it were ensuring that the practitioners were providing evidence-based induction protocols versus perhaps a small community rural hospital with 1 or 2 OBs that haven't been in residency, for years. Are they the most up-to-date on induction protocol? Do they allow that full time for cervical ripening? So that was another big point, taking a look at what your labor induction protocols are at your facility. That's important that they said before offering this universally to all pregnant women. And the third point that they brought up is really using shared decision making. I think that gets looked over a lot. Shared decision making is the concept of a provider and the patient, the parents, agreeing on a decision together, not a top-down approach of the provider saying, this is what you should do based on this study. So really taking into account what this woman, what these parents want for this birth in their experience. Again, the fact that over 16,000 women declined to participate in the first place shows me that a lot of women aren't necessarily interested in a highly medicalized birth or in induction. So, taking that time to really get to know your patients and ask them if this is a preference that they have after you've looked at the other 2 factors of, can your particular facility sustain this in terms of hospital resources? And what is the induction protocol? What are your rates of induction, failed induction, successful induction already as a provider? So what would I, Midwifay, kind of advise you to do when you're looking at this with your provider and deciding if an elective 39-week induction is right for you? I'd say that I agree with this ACNM statement. I am always first and foremost for physiologic birth. I think that that generally has the best outcomes for mom and baby. However, I also believe in a woman's choice to be able to have the birth that she wants. So when looking at this, I would encourage us to look at other ways that we can decrease the cesarean rate. Other methods at decreasing the cesarean rate, the primary cesarean rate specifically, which a lot of people want to do, that's the first time mom having a C-section, which again is about 30 to 34% on average in US hospitals. Some other ways that we can do this are universal midwifery care. We know from lots of different data, lots of different studies, that midwives have higher rates of spontaneous vaginal delivery than obstetricians. I strongly believe that if we implement midwife care in the hospital setting more, make it more accessible to more women, we're going to decrease the primary C-section rate. When you look at facilities that have midwives on staff, or looking at practices that have a large midwife population, those practices have lower overall cesarean rates as well as primary cesarean rates. So having universal access to midwifery care is a tried and true strategy to decreasing the C-section rate. Another viable strategy to decrease the C-section rate is providing continuous doula support or labor support for women. There are, again, a lot of studies that show that doula support, continuous labor support, decreases the cesarean rate. So this is another way that hospitals can maybe start a doula program. Practices can have doulas that are a part of their care that come into labor with women and support them and can help decrease the C-section rate that way. A third thing I would urge us to look at universally is a decrease in the use of continuous electronic fetal monitoring. That might be a little more controversial, but there's also a lot of evidence that continuous electronic fetal monitoring, those are the monitors that are on during labor to look at the baby's heart rate throughout the entire labor. We know in low-risk women that that leads to more interventions and higher level of C-section than is necessary. So, I think by implementing these three things universally, instead of universally inducing women at 39 weeks, these three things being more access to midwifery care, more access to labor support or doula care, decreasing the use of continuous EFM, all of this for low risk first-time moms, as the study was looking at, those three things, broadly one of those three things alone is going to significantly decrease the cesarean rate and at a much lower cost to the system than universally inducing people and spending hours and hours and hours on the labor and delivery unit. So if you're considering this and talking with your OB provider about this, I really encourage you to ask specific questions about that particular provider's induction rate and successful induction rate, meaning how many inductions end in a vaginal delivery, asking the same about the facility, what their induction methods are, asking specifics about how long, if your cervix is in that 0 to 5 Bishop score place, what tools would they use to allow your cervix to ripen and how long would they allow that to happen? I think those are really, really important questions that you have the right to ask your provider. Because just because this ARRIVE trial came out doesn't mean that your doctor with the 40% primary cesarean rate or your hospital facility with the 36% primary cesarean rate, this ARRIVE trial doesn't erase those things for your hospital, right, or for your provider. So I think it's really important for you as the birthing person to ask these questions and get specific. And if you get answers that are beneficial to you and that you are comfortable with and you want this labor induction, by all means, move forward with it. It's definitely a reasonable option. All right, you guys, I was really excited to film this video because, again, this has been something that has come up a lot lately in the OB world. If you work in OB, please comment down below. Let me know if you're seeing these inductions way more and how you feel about them. If you have had a risk-reducing or elective 39-week induction and had a good experience or a bad experience, also comment down below. I would love to get involved and hear from you guys. As always, please share this and subscribe. Thank you for watching, and I'll see you next time. Bye-bye.